Hello and welcome to our CPT coding review for the 30,000 series. This is part 3, and today we're going to be starting on page 245 in our 2020 CPT manual with arteries and veins. So the first set of procedures that we're going to look at are thrombectomy and embolectomy procedures. Now, these procedures are actually life-saving procedures that are typically performed in emergency situations. Oftentimes, the terms embolectomy and thrombectomy are actually used interchangeably. However, there are actually some differences between the two. And understanding the differences between these two terms is going to be critical in selecting your code assignment. So, a thrombus is usually a solid mass, like a stationary clot, whereas an embolus is when part or all of that clot is dislodged and it actually starts to move or travel through the circulatory system. So essentially, an embolus is actually a moving thrombus. In either case, these clots can definitely pose some serious and sometimes fatal risks. On page 245, what you'll want to notice is that our codes are first divided into arterial with or without a catheter, or venous direct or with a catheter. You'll also notice within the code families that the codes are divided based upon anatomical site. Next up, we're going to go over to page 246 for endovascular repair of the abdominal aorta and or iliac arteries. The first thing you want to notice on page 246 and page 247 and page 248 is that there are lots of subsection notes. And again, you've heard me say this a million times. You cannot take a national exam and the week or two before you're trying to read through all of the subsection notes. While you're learning CPT coding, now is the time to get familiar with the rules. These particular codes fall into the range of 34701 through 34832. Now, endovascular repair is actually a preferred treatment for many people that have a triple A, which is an abdominal aortic aneurysm. And it's actually also an alternative to those individuals that don't qualify for the open surgery to repair the abdominal aorta or the iliac arteries. As you begin to look at the code families on page 248 and 249, you're going to notice that many of them start off with the word endovascular repair. So it's going to be critical as you're reading through the description that you're able to differentiate the difference between them. And then you also are going to notice is that there is an indented code that starts off with for rupture. So take a moment to evaluate those codes and learn the differences between them. You will also notice with this procedure, there are some services that are actually built into the code. And that's why those paragraphs are so big because there are lots of services that are actually included in the code. There are also lots of parenthetical notes, so you want to make sure that you check out those as well. All right, next up, we're going to go on over to page 253 through 255. And here you're going to find fenestrated endovascular aneurysm repair, also known as fevar. Now, the University of Michigan actually had this really cool diagram of this procedure, and it's relatively new, probably within the last 5 or 6 years. Don't quote me on if it's 5 or 6 or 7 years, but it is a minimally invasive option for people who have abdominal aortic aneurysms who don't qualify for the traditional endovascular aneurysm repair, which is EVAR instead of FEVAR. The traditional EVAR works when aneurysms are located far enough from the renal areas, the renal arteries, which actually branch off the aorta, and the stent can actually be securely attached to the aorta. Now, on page 253, of course, it starts off with subsection notes. And then on page 254, that's where you have the code options that are available for this particular code family. Next up, on page 255, we have codes for direct repair of an aneurysm or excision and or graft for aneurysm, pseudoaneurysm, ruptured aneurysm, and associated occlusive diseases. Now, these codes start on page 255 and include code range 35001 through 35152. And on page 255, one of the things that you'll note is that you have the standalone code at 35001 and then lots of indented codes that basically differentiate the different options that are available for this particular code family. In most cases with this procedure, they are making that incision into the neck. And they're able to really go in there and remove that fat or plaque. Next up, we have on page 256, we have our thromboinectomy codes. And this is a procedure that is actually performed to open an artery. I don't know if you notice a theme with a lot of these procedures. They have a goal of actually opening up the artery that is occluded, also known as obstructed by a thrombus, which is also known as a blood clot. This particular procedure is actually performed through an external incision rather than through a blood vessel. And then that occluding thrombus is then removed. And removing the thrombus includes pulling out the fatty deposits that are in the inner lining of that diseased artery. And you can see the picture here where the plaque is actually sitting there right in the middle of that artery, which is restricting the blood flow. And then once they do this procedure, you'll notice how it's wide open so that the blood can flow like normal. Now, on page 256, you start off with the standalone code of 35301, and then the code family then continues with the options of different arteries that can be used for the procedure. Then there is an add-on code of 35390, which is utilized when there is a reoperation of a carotid thromboinectomy more than 1 month after the original operation. All right, next up. Okay, guys, this is the fun, and I'm being facetious here, the fun part of this particular chapter. And these are the vascular injection procedures, which is going to actually take us over to page 262. And this is going to be codes 36000 all the way through 36680. Now, the codes that you see here, the one thing I want you to notice is that it starts off talking about actually what's included in these procedures because there's a lot of services that are included. The other thing I want you to take note is that this is the area where you're going to see lots of selective and non-selective catheter placement. I talked about that at the beginning of the cardiovascular video, the second series. So to review, non-selective catheter placement refers to a catheter that remains in that vessel that was accessed or has made it into the aorta, and it's considered non-selective. Whereas selective is when the catheter is placed not necessarily near or at the origin into a branch off of the aorta or the access vessel. And then each of these vessels that are arising from the aorta, we talked about this before, or the access point is going to represent a vascular family. The other thing that is very important to note here is that when you're coding the selective catheter procedures, you want to code to where the tip of the diagnostic or working catheter is placed, but not the wire, because you're going to see wires in the documentation. And so a working catheter could be something like an angioplasty or an atherectomy or a stent catheter. So as it relates to selective catheterization or catheter placement, something that you need to know is that the documentation has to state selective, the catheter, cannulated, went into, was parked into the artery. Without that documentation, you really don't have enough to support the selection of the catheter placement codes. So vascular access is actually going to be the location of where the patient's vascular system was actually entered. And when you're reading these reports, you can actually follow that process by just taking care to read each and every line, each and every word, and you can see where they're going with this procedure. Now, I will tell you that there is actually a whole certification dedicated to this type of coding. It's actually called interventional radiology or cardiovascular coding, and it does require advanced knowledge of cardiac anatomy. So, on a coding exam such as the CPC, um, I would not spend a lot of time trying to master this concept because there is a whole certification that's dedicated to this particular area, and you want to be able to move on to the next family of codes. Now, with this type of procedure, one of the things that you're going to notice is that some of these services will require a code from the surgery section where we're in now, as well as a radiology code to reflect the imaging portion of the procedure. And so, what I mean by that is when they put those catheters into those vessels and they shoot the dye up in there, so vascular injection, they need the imaging to take pictures and tell what they actually see in this particular code family. So there are some guidelines that start on page 263 with definitions. Definitely recommend that you review those. Watch out again for the word selective versus non-selective. And I want to just talk about kind of a couple of codes here, starting with 36200, which is on page 264. Now, with 36200, this is where the catheter placement was only in the aorta. Okay. So it's inserted and it just stops at the aorta. So this is your non selective catheterization. Usually, and this is one of them, this one in particular, they're stopping pretty much at the aorta. Um, Also, with this particular procedure, you'll find in the documentation that they're accessing this area by actually going in through the femoral artery or they're going in through the radial artery. Now, once the catheter is placed into what is known as a selective artery, so if they go past the aorta into the different vascular families, the non-selective code is actually not coded and it's basically bundled in with the highest order that you're going to select for the catheter placement. And so here's actually a picture of the aorta. Um, and I'm pretty sure that you've actually already seen this before. All right, so speaking of order, you heard me mention order. So if you actually start to explore this code family, if you start with 36215, you'll notice that it states selective catheter placement, arterial system, each order, thoracic or brachiocephalic within a vascular family. And then the next two codes get into second order and third order. So vascular order actually describes the level of a vessel. The initial vessel off of the aorta or the access vessel is actually considered first order, and it'll be documented in the record. When this initial vessel starts to branch, it becomes smaller and more difficult for the provider to catheterize, resulting in the branches becoming our second order selections. And then when the second order vessel starts to split off or bifurcate, the resulting branches become third order and so forth and so on. The highest level of selection in a system such as arterial is actually the third order. So it's not necessary to distinguish the higher levels of selection because the third order is the highest that we have in our code book. Um, so let's take a look at, um, let's go to the bottom of page 265 and let's take a look at arterial. So 36245. And a few seconds ago, I was looking at 36215. You notice they both say selective catheter placement arterial system, but 36215 says each first order thoracic or brachiocephalic branch, whereas 36245 says pelvic. So don't forget about the appendix in the back that actually gives you the different vascular families because that's something that is critical. So using 36245 as an example of first order, here basically the catheter is only manipulated once into another vessel, typically the common iliac. Second order, the catheter is manipulated twice, and that is the vessel's internal and external iliac and common femoral. Again, look at that diagram in Appendix P as you look at the code so you can see how these systems branch off into first, second, and third order. And then third order, which would be page 266 for this particular family I'm talking about, the catheter is manipulated 3 times. And then here you're talking about the superficial femoral artery and any arteries that are below it. So if you evaluate each of the different systems and follow the path of the orders, you should be able to get a basic understanding. Again, do not try and get an extreme advanced order of this for understanding of this because interventional cardiology has its own certification. You can actually look it up, CIRCC. It's way beyond what I'm actually covering here today. All right. So next up, we're going to go over to our venipuncture codes on page 266. And this is where we get codes for blood draw. And so here we have codes 36400 through 36460. And in addition to just regular blood draw codes, if they're going into the vein, we also have codes 36430 for if they're doing like a transfusion. And we have several transfusion options to actually take a look at on this particular page. All right, next up, we're going to go over to page 270. And on page 270, actually all the way over to page 276, we have what are known as central venous access procedures. This is a procedure that is performed in about 8% of patients that are hospitalized. And so that really is about, based on my research, is about 5 million catheters are inserted in the hospital every year. And so doctors actually recommend that a patient gets a central venous access catheter if they have to undergo dialysis or chemotherapy treatments, or for patients that need to receive frequent antibiotics or blood draws while they're in the hospital, as well as patients that have nutritional supplements. So on page 270, it starts off with some subsection notes. And something that you need to know that's very important is that a central venous access device is defined as a catheter whose tip is going to be located in either the central vena cava, the right atrium, or the inferior vena cava. And it actually states it somewhere, somewhere in this particular area, that's a requirement. Now, from a coding perspective, one of the things that you need to look at is, was the procedure today an insertion? Or was it a repair? Was it a replacement? Was the replacement partial or complete? Was this a removal? So you need to know, what's actually happening today. You also need to know if the catheter was tunneled or non-tunneled. And then you also need to know the age of the patient. And this is going to be important because that's how the codes are actually set up. So on page 274 in your CPT book, there is a really cool table that will help you plot out basically what code you would be using. But again, you have to know, is it an insertion, repair, replacement? Is it partial, complete? Was it a removal? And also, did they reposition it? As well as, was it tunneled, non-tunneled? Was there a pump? Was there a port? What's the age of the patient? Oh, and the other thing is it centrally inserted, or was it peripherally inserted? And all of this will be in the documentation. And one of the things that you really have to realize is that with coding, you got to know the rules for coding that particular code family so that you can pull out that information from the medical record. All right, next up, we're going to go on to our hemodialysis access procedures. And hemodialysis access procedures are for patients who obviously need to have dialysis. And before they can get the dialysis, they have to have this AV device inserted. So usually once a patient's kidney function goes below 10 to 15% of normal dialysis treatment, or normal, the patient requires dialysis treatment, or they require a kidney transplant to continue to live. And so there are two types of dialysis, hemodialysis and peritoneal dialysis. And both of these are done to replace the kidney's function by cleaning the blood of toxins and removing the extra fluids that are usually associated when people have kidney failure. So what you're going to notice over here, that you're going to see an arteriovenous fistula and an arteriovenous graft. Now, an arteriovenous graft is actually created by connecting a vein to an artery using a soft plastic tube. After the graft has healed, hemodialysis is performed by placing two needles, one on the arterial side and one on the venous side of the graft, AV, arteriovenous. The graft then allows for increased blood flow. Now, a fistula is going to be used for hemodialysis, and it is actually a direct connection of an artery to a vein. And once the fistula is created, it is a natural part of the body. And this is the preferred type of access because once the fistula actually matures, it gets bigger and it gets stronger, and it provides an access with good blood flow that can actually last for decades. Now, after the fistula is surgically created, it could actually take weeks or months for the fistula to mature and is ready for hemodialysis. So here, what you have on page 276 and 277 is actually the procedure for the insertion, but the dialysis itself is actually coded in the medicine section of our CPT manual. All right, next up, we have our dialysis circuit codes, which start on page 277. And this is a relatively new procedure. And the CPT manual actually utilizes the term dialysis circuit to refer to both H, arteriovenous fistula and arteriovenous graft. And dialysis circuits can actually be placed at several locations in either the forearm, the elbow, or the upper arm. And an arteriovenous dialysis circuit is surgically created for long-term hemodialysis in patients with end-stage renal disease. And there are actually two types of dialysis circuits, both of which involve the creation of an artificial communication between an artery and a vein. An arteriovenous fistula is surgically created, and it basically creates what is known as an anastomosis, which is a connection. And in this case, it's a connection between an artery and a vein, and it allows some of the blood to pass directly from the artery into the vein while the rest continues down the artery to the distal part of the limb. And so essentially what happens is that the presence of this fistula is going to increase the blood flow through the vein. Since some of the blood is actually going directly into the vein rather than passing through the distal capillary bed. And this increased blood flow causes a series of changes in the vein. And of course, it becomes larger, it becomes easier to see. And this is a process that is called maturation. And this generally takes about a month. And of course, once it is matured, it's ready to be used in dialysis. So this particular area starts off with more subsection notes, page 277, 278, 279, and then from there you actually have the code options that are available. All right, next up we have our transcatheter procedures on page 281. And here you'll see procedures like mechanical thrombectomy, arterial thrombectomy. Mechanical thrombectomy is a type of minimally invasive procedure which an interventional radiologist uses specialized equipment to remove the clot from the patient's artery. Usually they're going to use fluoroscopy or some type of continuous x-ray to guide those instruments through the patient's arteries to the clot and then taking the clot out all at once. So the whole objective is to take out that clot, and then at the end, they repair that blood vessel. So from a coding perspective, over on page 282, you'll see options for mechanical thrombectomy as well as, and they're divided into venous and arterial thrombectomy. All right, next up, we have endovascular revascularization on page 294. And if you think about it, the heart is just so complex, and all of these different procedures that you're learning about just really, confirms how complex it is. Now, this particular procedure, endovascular revascularization, is performed to clear blockages in the arteries and to remove the plaque, athero, that's causing the decreased blood flow. I don't know if you've noticed this by now, but a lot of these procedures, your patients are having, or the patients are having, decreased blood flow, and the treatment of choice is based on each individual patient. Now, with this particular procedure, um, it actually alleviates the pain and stops the tissue decay or loss that's associated with lower extremity peripheral artery disease. And this is a procedure that they do in non-surgical candidates. It's faster than a coronary artery bypass. And it actually has a faster recovery time, with most patients being able to get back to their normal activities in a few days. So on page 284 and 285, more subsection notes. I think the cardiovascular section has more subsection notes than any of the options. So what you'll notice is that these procedures are divided into open or percutaneous. They're also divided based upon the vessels that they're using. You'll also notice that several of them have the word unilateral as a part of the procedure, as well as initial vessel. And then we also have codes for stent placement, because sometimes they have to put in a stent to keep that vessel open once they, unclog it. All right. Let's see. Next up, we have vascular embolization procedures. And here we're on page 290, and we start off again with more subsection notes. Now, why are the subsection notes important? Because they tell you what you should or should not be coding in a particular code family. And for example, with this particular code family, the embolization codes here include a lot of stuff. The associated radiological supervision and interpretation, intraprocedural guidance, road mapping, imaging, that's necessary to document the completion of the procedure. But then they also tell us what can be coded separately, if we need if we need a modifier. But then it also tells us that these codes are reported per surgical field. And that's why guidelines are so very important. All right, next up, we're on page 291 with our intravascular ultrasound codes. These are add-on codes, and there is a long list of codes that these two particular codes can actually be used with. So you'll want to make sure that you review those notes for that code family. All right, next up, guys, we're going to go to some things that are not as difficult. On page 292, I'm looking at our ligation codes. Ligation is a procedure that means that they're surgically tying the veins through a small incision to prevent pooling of blood. Ligation as a procedure can be performed in conjunction with vein stripping or removal of the vein. And in many instances, the vein is removed using minimally invasive surgical procedure, also known as a venous ablation. These procedures, like your ligation, division, and stripping procedures, are done for two main reasons. One, and you see these commercials all the time, the patient has varicose veins. And in conjunction with the removal of the varicose veins, they're doing the ligation and the stripping to prevent the varicose veins from reoccurring. And this is typically done if there is evidence that the patient has valvular incompetence within the main veins that actually give the rise to the varicose veins. All right, so those are those codes there. Watch out for words like long and short saphenous veins, and again, what's included. And there are parenthetical notes about do not code this with that, etc. All right, next up, we're going to get to, again, some easier ones, page 293, under hemic and lymphatic. And so we've officially left out of the cardio, but these are still in the 30,000 series, so I'm going to continue. And so here, we have our splenectomy procedures. Now, what you want to note under excision on page 293, we have our open splenectomy procedures. And then when you get down to 38120, we have our laparoscopic procedure. So you still want to pay attention with regards to if a procedure is endoscopic or it's open or percutaneous. All right, next up on page 294, under general, we have our bone marrow or stem cell services. And here you're going to see a variety of procedures that are done to preserve, prepare, and purify bone marrow or stem cells prior to the patient getting the transplantation and reinfusion. Each of these codes can be used once per day, regardless of the quantity of bone marrow or stem cell that's actually manipulated. Another reason for reading those notes. All right, next up, we have our hematopoetic cell transplantation. And this is actually an autologous procedure, auto means self. Um, it's the intravenous infusion of the hematopoietic stem and progenitor cells designed to reestablish marrow and immune function in patients in a variety of acquired malignant disorders who are being treated with high dose chemotherapy or chemoradiotherapy to prevent disease. And usually you see this with patients that have Hodgkin's lymphoma, B and T cell lymphoma, or multiple myeloma, all the omas. And so HCT, hematopoietic cell transplantation, is also used in support of patients that have certain solid tumors for whom hematologic toxicity would otherwise limit drug administration. All right, next up, we're going to go over to page 296. We're now under lymph node and lymphatic channels. And here we have codes for biopsy under excision on page 296. What I want you to note here is that 38500 is for biopsy or excision of a lymph node or nodes. And our first option is open. Then we have by needle. Then we have open deep cervical nodes, with excision of a scalene fat pad, open deep axillary nodes, open internal mammary nodes, open inguinofemoral node. So you got to know what part of the body, what lymph node is actually being worked on. All right, next up, we have lymphadenectomy procedures on page 297. And with these particular codes, you probably notice on this diagram here that I am showing a picture of an endoscopic procedure. And you can always tell an endoscopic procedure, and this is the one on the right side, you can always tell an endoscopic procedure because of the devices that are used. You can tell the difference. Whereas with the open procedure, remember the procedure is open to the physician's naked eye. So when you're reading the operative report, you want to be looking out for key things like, are they using trocars and ports, or are they telling you that they're using some devices to grasp and hold the area open and it's open to the physician's naked eye. All right, almost done here. We're going to go over to page 298 under mediastinum and diaphragm. And first, under mediastinum, you're going to see a mediastenotomy, which is basically a surgical opening of the mediastinum. Um, the mediastenotomy actually gives direct access to the aortopulmonary window. Um, which are actually not able to be accessed via a mediastinoscopy. So sometimes they have to open them up, and other times they can just um, insert a scope. And lastly, we made it out of the 30,000 series. Under diaphragm, page 299, we have a code family of repair. And here you have repair of different hernias of the diaphragm. And they're divided. Some of them are for neonates. Um, One example of a good parenthetical note here, if you look at code 39503, with this particular code, because it says neonatal in the procedure, we actually do not use a modifier 63. Now, when we get over to the 40,000 series and the digestive system, we actually are going to look at some different types of hernias. So note that these hernias are actually diaphragmatic hernias. All right. Well, that was the 30,000 series. We finally made it to the end. Next up, we have 40,000 series.